Well, good afternoon. Thank you, Donna, for the kind introduction, and thank you to the John Locke Foundation for inviting me here. I have always appreciated that while we may come at some issues from different perspectives, I actually think that there is a lot of alignment on the kinds of things that we're trying to achieve around access and quality and value for the dollars that we're spending. And I am very conscious as a steward of public resources that we need to be very transparent in the way in which we go about our work, and I hope that we have done that over the last 2 years that I've been in North Carolina. Actually, last year was my 2-year anniversary being here in North Carolina. It's been a fun 2 years. But before I launch into an overview of the work that we are trying to do at the department, and I'm going to touch on those 3 priorities that Donna mentioned, I thought I would start where I often start a lot of my talks, is talk about a patient that I took care of when I was first training to be a physician. And I share that story because I think it has a lot of lessons and helps you understand how I approach the work at the department, and has shaped a lot of my thinking on how we use our tools of public policy to really shape good solutions for people. And so I was training in internal medicine. It was my 3rd year, so I'm nearly done. I went to some pretty good schools before that, and I was feeling pretty good about myself as a doctor. And and I was in my primary care clinic, and I saw a patient that's pretty typical. I saw a 24-year-old woman. She had insurance. She had Blue Cross Blue Shield of Massachusetts. I was training at Mass General at the time, so she had private insurance. She's a full-time college student, and she came in with some vague complaints. She was tired. She was losing weight, and she was losing her hair. And so, I do what doctors do best. Think about your experience going to the doctor, right? They ask you really personal questions that you don't talk about at parties. I asked her about her menstrual period and diarrhea. I asked her about her family history and medicine she's taken. I did a physical exam. And after all of that, I did what doctors also do best, is I ordered a lot of lab tests. And I'm still early in my training, and we joke sort of when you're earlier in your training, you think it's all of these things. So I ordered a lot of lab tests. I thought maybe she had anemia. I thought maybe she had a thyroid disorder. I was thinking, in Massachusetts, maybe she had Lyme disease. Of course, I ordered them all at the same time. They all came back normal, which is good. Okay, so not anemia, not thyroid, not Lyme disease. I talked to her. Now, this is where I'm not sure if I talked to her on the phone or I saw her in the office, but she was looking ill. And one of the skills you develop as a doctor is like looking ill, not looking ill. And she was looking ill, so I was concerned about her. And so she was also now starting to complain of some belly pain and fullness. And I was like, okay, maybe there's something going on there. Let me do a CAT scan of her belly. So I do a CAT scan of her belly, normal. So she's back. I've known her now 8 weeks. And so she's back in the office. And now I'm about to see her, and I'm talking to my preceptor, right? Because I said I'm still training. And so I'm talking to sort of my mentor, and to say, like, what do I do here? Everything was normal. Look at all of these things. What do you think we should do next? And we're literally debating what specialist should I send her to next. When my tech, the woman who checks in, takes your vitals down and things like that, comes over sort of with a piece of paper with the vitals and kind of hears us debating what specialist I should send her to. And she says, I really think you need to ask your patient if she has enough to eat. And it was a haunting moment for me, even as I recounted every time I tell this story. Right, because you get immediately defensive, like it's a human reaction to be like, she has enough to eat. Look, she looks perfectly put together. She has insurance. She's a full-time student. I'm sure she would have told me if there was, something in that space. Second, I start to think, oh my gosh, she hasn't eaten for 8 weeks because of me, right? I didn't ask her something fundamental to her health, like, do you have enough to eat? And sort of like what's going on outside of the paradigm of healthcare. And then I started to get anxious. I was like, oh gosh, I have 3 people waiting in the waiting room. What if I go in and we talk about, do you have enough to eat? And she says, yeah, I don't have enough to eat. What am I gonna do about that? Like, I didn't feel equipped. In the years of medical school and the years of residency, I did not feel equipped to know what to do with the answer to that question. And so I walk in, and I'm going to talk about some of the things we want to do better, but I did a terrible job of asking any sort of standardized questions. I basically went back in the room and said, is something going on at home? And clearly, because she had indicated something to my tech, that she, I think for the first time, was putting together some pieces of her own life, that what was going on physically with her was actually being interacted with what was going on with her personally. And so when I was able to ask her what was going on at home, she opened up to share. She was like, actually, I'm living out of my car because I just left an abusive relationship a few months back, and I'm embarrassed to call my parents because they really loved the boyfriend. They thought we were going to get married, and I don't want to tell them. And there's a lot of shame involved in that. And so she was basically living out of her car. She was able to sort of eat. There's sort of at college free food around, sort of at lunchtime. But essentially going without food. And she was having her own cognitive dissonance, as we often can, that we sort of compartmentalize what's kind of going on in our personal life and what we're feeling physically, but we know it's one and the same. And once we were able to sort of start to unravel all of these, I was able to get her help. I talked to the folks at the college, and she did have insurance, but I share the story because I couldn't have done more things wrong there. And I spent money. I spent thousands of healthcare dollars, and I didn't get her one bit closer to being healthy, right? And it just speaks to how do we think about all of these levers and all the things that we have at our disposal. You heard $20 billion in my department. How do we use all of those levers in a smarter, more effective way so we're actually getting at the root of what drives health, right? For my patient, it wasn't a Lyme disease test, right? It was really the root of like her housing stability and food stability. And so, that's how, I share that story so you can understand sort of how I think about the kinds of tools that we have and how do we really build those healthier communities. Because I do think that healthcare is clearly important. Look, I trained to be a physician. I think it's really important to have access to high quality physicians, but we have to realize that health is so much bigger than what happens in the four walls of a hospital or a clinic. I mean, think about your own personal health and what contributes to that. I bet the first image that comes to your mind is not your primary care doctor, right? It's probably a lot of other things. And so that is how we really are thinking about our work overall here. And as I dive into the work, and even as I think about our priorities, that is really where I am focused, about really trying to build that more efficient and effective system so that we get at health. And so, I wanted to start in a place where I think we have a lot of alignment and shared priorities around how we move forward with the work and sort of providing folks with tools to make those healthier choices for themselves. And so, right, and how do we enable our system to make that possible? How do we reward outcomes? I'm going to talk a lot about our Medicaid program in particular, and how do we use the quality metrics and value metrics to really get to outcomes and not just checking the box processes, right? How do we get to that outcome focused? How do we alleviate administrative burden, but still getting that accountability, right? So we want to make sure that everyone's not buried in paperwork, but I am a steward of taxpayer dollars, so how do you balance that with ensuring that accountability and program integrity? And I think we'll talk through some of that. And when I look at sort of a scorecard of like where are we in North Carolina and how well are we doing, you look overall in terms of our health status as a state compared to the other 50 states, we rank 37th compared to the other 50 states. So that's not average, that's below average. And I'm a competitive person. I imagine a lot of you in this room care very deeply about North Carolina, right? We need to do a lot better. And it's understanding what goes into that 37th that is really important. So for example, we're 37th overall, but if you look at certain statistics that really tell you about what's happening at the ground level in a community, I like to look at a statistic related to infant mortality because it's such a complex way in which you get to a statistic. So infant mortality is the number of babies that don't make it to their first birthday. We know that there's a lot of factors that influence that. Health of mom and her pregnancy has a lot to do with it, and then health of baby and what is going on once baby is sort of in the world. And what's significant about infant mortality for North Carolina is that for the nation, we are above average in terms of our overall infant mortality, but there is a huge rural-urban divide here in North Carolina. And so I showed you about in Clay County, while on average there's about 7 babies don't make it to, out of 1,000 don't make it to their first birthday. In Clay County, it's 22 out of 1,000. And that just shows you that we have a lot of work to do in terms of shoring up how do we think about the health of our state overall in different parts of our state. Also on the opioid front, right? We have been a state that has been hard hit by the opioid crisis. Now we're making some progress, and I'll talk you through some of where we're making a dent there, but we know there's still a lot of disparity in where we're making progress and where folks can get access to care and not. And then if you look at something like veterans' economic well-being and quality of life, we're a military state, yet somehow we're ranking 21st in what we're able to do for our veterans. Again, just to paint a picture of like there's a lot of room for improvement, and we are focused on, because of that, focused on, as Donna mentioned, these 3 priorities, and that's what I'll go through. And I'm focusing on buying health, and I use that term intentionally, right? Because I want to get value out of every dollar that we are spending and really buy health for North Carolina. And to do that, I think we need to think differently. And frankly, we need to work differently at our department. And so we'll talk about that. But our 3 areas of focus: Medicaid transformation, opioid crisis, and early childhood. And so I'll go through each one of those. As you probably likely know, that we are undergoing a big change in the Medicaid program that was initiated by the General Assembly a number of years before I joined the team in North Carolina. But just to remind folks, as sort of level setting of like the Medicaid program itself, just to give you a sense of it's a lot of folks, right? We're about a 10 billion person state, 2.1 million people on Medicaid. It's 1 in 5. But when you think of, okay, who is a Medicaid beneficiary, you can actually see that children are 54% of the program. So the most number of folks who are on our program are children. But children are generally healthy, right? Kids are generally healthy. So they actually, even though they're half of the program, they represent about 22% of spending. Then if you look at the other big chunk of our program, the majority of our, I shouldn't say the majority, but almost half of our spending are from folks with more severe medical conditions and have a disability, but they're about 15% of the program. And then seniors, and this is seniors often in long-term care facilities, they're just a small piece of the program, 6%, but you can see again a lot of spending in that space. So we are starting actually with the middle category of basically with moms and kids and children, and thinking about how do we change the way in which we pay for care related to them, and then we will slowly phase in the folks with disabilities, and then you get to seniors. So 2015, that's when General Assembly voted for us to change the way in which we pay Medicaid. Right now, the Medicaid program pays the bills to doctors and hospitals directly. In managed care, we will delegate that authority of paying the bills essentially to insurance companies. And so over the last 2 years, we've been doing a ton of work to get ready for that, and this is actually going to be later this year, the first year in which we're actually going to start managed care. We've done a ton of collaboration to try to get the policy right, because this is hard, and it does, as I said, it impacts a lot of folks. In the first wave of our move to managed care, we're going to be moving 1.6 million people into managed care. We are the largest state that has not moved Medicaid to managed care, which is good in a lot of ways, because we can look at a lot of other states and learn lessons from them. We can learn what not to do, and I think we have brought a lot of good lessons from around the state on what to do. And so we really have architected the program around these primary commitments. One is to deliver whole person care, and that has to do with coordinating in a different way. Right now, we pay for physical health and mental health in very siloed ways, and that means delivery of care ends up being very siloed. Again, I'm looking for those ways in which we can gain efficiency and effectiveness, really thinking about the whole person together. So we spent a lot of work over the last 2 years and with the General Assembly for a path forward on how do we integrate physical and mental health. Second, we want to address the full factors that impact health, right? Think about my patient with insurance. I want to make sure we're thinking broadly about it, so I'm excited to tell you about some investments we're making there. We also want to make sure we're investing in localized care management. I want folks to get the right care at the right time in the right setting. And that means some navigational support and care management support for folks who get it close to folks in their homes and in their practices. And then I want to make sure our beneficiaries, those 1.6 million folks, most of them are kids, I want to make sure that there are that the doctors and nurses and hospitals are there to see our patients as we move into this. And so that administrative burden, the paperwork piece, is really on top of mind for me. So the key features, I've sort of started to touch on them. So this focus on whole person, this behavioral health integration. So it is going to be across the whole program, which is a new legislative change as of last year. That was embedded in our waiver that we asked the federal government. We had to get approval from federal government to move forward, which we did at the end of last year. But that whole person, like I said, also means focusing on those unmet social needs because, right, I'm not interested in throwing good money after bad. How do we really get upstream? Second is around that promoting quality and practice-based care management. We are trying to help independent doctors in particular and practices take on the responsibility of doing the care coordination. So we know that doctors are seeing patients in their office. We also want them to sort of be the quarterback, if you will, to help folks navigate around the system. Maybe not them themselves, but they're a case manager or someone very embedded in their practice. So that's our advanced medical home program. We also have a statewide quality strategy, and this is where we're trying to do a lot of work to get to some core measures that are outcome focused. Harder to do than you might think in terms of measurement. But we are very focused on things like asthma care and diabetes care and others in our quality strategy. And then lastly, paying for value. This is a big focus for me and I think aligns with where other payers of care are moving. I think you heard a recent announcement from Blue Cross Blue Shield just a couple weeks ago about their move to value, meaning paying differently. Meaning that we pay right now in our Medicaid program, we pay piece by piece by piece. Right? If you're, think about my story, right? If you order a Lyme disease test or you order a thyroid test, we pay for it. As we move into the future, we really want to start to think differently about using our payment levers to say, I want to pay you for outcomes. I want to pay you to keep folks out of the hospital, to keep them well. And so we want to move to these alternative payment models that align with where Medicare has gone in terms of payment and where now you're seeing the commercial space, as Blue Cross Blue Shield's announcement showed. So we have embedded these rules into our managed care program as well, so that we're moving down that path by the second year. So a couple of words on the administrative burden piece, because this is, I think, incredibly important, again, so we can make sure that folks have someone to see when we make this transition. So some of this is about streamlining credentialing. This is so I have enough providers in the queue. We want to make sure that transparent payments are there. We're standardizing quality measures. We're trying to get standard prior authorization forms. By law, we have a single statewide preferred drug list. So that means that every insurance company doesn't have their own drug list. We have a centralized one that, again, cuts down on administrative burden, and it does smooth things for our beneficiaries. They have to our insurance companies have to cover the same services as Medicaid does right now, and we're going to have this consistent definition of medical necessity. Again, all of these things are trying to create consistency and efficiency as we move to managed care. I wanted to make sure to point out some of our tools around accountability and oversight. A number of these are dictated in state law, others in policy. For example, the statute sets medical loss ratio points, and this is the amount that you must spend on medical care versus administration, right? So that is set in statute. we have tons of things in a very, very long RFP that we put out that holds PHPs responsible for quality and outcomes and compliance with program integrity. And a lot of different standards, and so this is a new space for my department to be in, to be regulators of this, and I think that we have learned a lot of lessons from regulating a small amount of managed care in the mental health space, but this is a whole new level. So we are certainly building out our competencies in being able to do good accountability and oversight. Sorry. Okay, so let me just leave you with some of the timeline here. So as I mentioned, fall of last year, we got our 1115 waiver approved by the federal government. Basically, that gave us the green light to move forward with managed care. We put out a big request for proposals for those insurance companies to participate in the program. We are going to be awarding those in the next couple of weeks here. So that is like the first real official kickoff to managed care. And once that starts to happen, we're going to work on all of the operational pieces that it takes to actually launch managed care. So folks will start to see this summer is the first time where we're actually going to talk to our beneficiaries and say, hey, managed care is coming this summer, pay attention. We're going to be rolling out managed care in 2 phases for the moms and kids piece. And this is because, in my past life, I've lived through some IT projects that did not go well the first time. And we've learned some lessons about wanting to make sure that we get all of the operational and IT things worked out before we really go live across the whole state. So we will be announcing very shortly sort of 2 regions of the state where we'll go live first. That'll allow us to work out any of the kinks, because look, any big IT project, whether you're Apple or you're the state, they have there are issues to work out, and so we want to make sure we get that right, because this is people's lives and their care, and want to make sure that we are doing that as smoothly as possible. So start for the summer. We will start phase 1 in November 1st of 2019, and then the rest of the state will go live February of 2019. So I'm excited about this piece of the Medicaid transition that it talks about investing in healthy opportunities. And this is my words to talk about how do we really think about linking together what's going on in the healthcare space, right? And all the dollars that are spent in the healthcare space and all of what's going on in the community. And it's really thinking about my patient that I was talking about, and how do we do better for someone like her as we build this system. And so we're thinking about ways of embedding that work across the board here, but let me talk about 3. First is about screening questions. Remember when I went in and said, hey, what's going on at home? That was not the best way to do that, obviously. And so one of the things we have to do is make this part of what we do, both as doctors as well as the insurance companies, to be asking those questions so we can understand how to navigate folks to the right resources at the right time. So we worked we had an open process to create these standardized screening questions. It's 8 or 9 questions that asks about food insecurity and transportation and housing and jobs and interpersonal violence, right? So it is required for all of our managed care plans to do that screening, and again, I think it helps you understand whether someone needs particular resources. The second piece of the pie is, okay, well, if I had that patient who says, yeah, doc, I'm food insecure, so I don't want all the doctors to worry that they won't be able to know what to do if someone actually says that in their office. And so this is where the resource platform comes in. And this is a philanthropic-driven private-public partnership to build a platform, an IT platform, to help us link together what's going on in the healthcare space and what's going on with the community. And let me give you an example. So let's go back to my patient. If I was, my patient said, I'm having trouble with food, particularly at the end of the month, I could say, great, let me send you to a food bank that's near your home. And then not only can I tell her where that food bank is through this database, but I can send a message to that food bank saying, hey, my patient's on its way. let me know if she doesn't show up. And when she does, the food bank also knows that she was sent there by me or my office, and they can report back, yes, she made it here and she made it in this time, and these are the kind of resources. So it gives you that closed loop referral, which is really important. Often as doctors, and I'll tell you from my patient, we are say, oh no, why don't you go get help from X, Y, and Z partner, and you sort of never really know if that happens or not. You hope maybe you're really on top of it and you make phone calls and try to follow up with the patient or some of those organizations, but it's really time intensive. So we're hoping this platform can streamline this. And again, this is a partnership through the Foundation for Healthcare Leadership and Innovation to build this NC Care 360. We're going to be rolling it out first in Guilford County and Wake County. So that's coming in actually in the next couple of months, and we're really excited about that. And I'm sure we'll learn a lot of lessons there in those first two counties, but we, again, continue to raise some philanthropic dollars to allow that to be in as many communities as possible. And I will say that hospitals and doctors, they've been essentially doing a lot of this in the background, right? Like I did for my patient. They're super excited to have a platform that will allow them to do better connections to resources in their community. Now, it doesn't mean there's going to be magically enough resources there, right? It is just an IT platform, but I think it's already starting to help some folks in the healthcare space know about what's happening in the community. Often they aren't even in the same room at the same meeting, so we're really excited about that. But the thing that I think is going to make North Carolina the leader in this space in terms of driving forward is this regional pilot, and this was part of our 1115 waiver, where we know that there's been small studies that show if you do certain interventions that you can save healthcare dollars and improve costs. And I'll give you another example for kids in particular. Kids with severe asthma wind up in the emergency room a lot. Where's the most expensive place to get care? The emergency room. It's not coordinated, it's expensive, they have to do rescue things. It also it takes kids out of school, mom and dad are not at work, not a good overall situation. So in Guilford County, they piloted a program where they went into the kids' homes, ripped up their carpet, put down new carpet, and gave the kids an air filter. And anyone who has kids with asthma or has asthma themselves know that when you decrease the triggers, you're going to be in the emergency room less, right? So it means you're spending less money. Even if you pay for that carpet, it's less than one emergency room visit to pay for that carpet. Right? And so then you're saving money, kids are at school learning, their health is better, mom and dad are at work, right? Win. What I want to do with the regional pilots, one, is expand something like that further, right? And so how do we get all kids with severe asthma to get that kind of intervention and use Medicaid dollars to pay for those kinds of interventions? But then let's get to the next turn of things, right? I care very much about high-risk pregnant moms. I pay for half the births in the state of North Carolina through Medicaid, which means I also pay for a ton of NICU care, which is very expensive. So are there interventions that we can do for mom related to food or transportation to her prenatal visits or others so that she carries the baby to term, has a healthier overall pregnancy, and that baby gets off to a good start in life and hopefully not in the NICU at all, right? And so how do we think about those interventions? We need to test it out, right? We don't know. We have very small studies that are evidence-based that can show us, and we want to take that to scale. And so the federal government gave us the opportunity to run this pilot as we move to managed care. And so we're embedding it in managed care, which I'm very excited about, because that is how most Medicaid programs are run throughout the country, and we're going to run here. But it is really about learning. What are those interventions around housing or food or transportation or jobs or violence that can really move the needle on health and reduce costs? And it will require a lot of evaluation as we go, but I'm really excited about it. And again, I think it puts North Carolina on the leading edge of thinking about this kind of linkages and effectiveness and efficiency. And I just wanted to share, I think this has been a fantastic bipartisan partnership here. Obviously, it was the Trump administration that approved our waiver. And in fact, the administrator of CMS went further than just saying approve. She's actually has given a number of talks on this and then wrote a piece talking about North Carolina's leading work in this space about this program. So I'm very excited about it, and it's a lot of work, I'm not gonna lie, to make this go, but wanted to highlight that for you, and I think it's an exciting place. So let's talk about a topic that I know some of us don't agree on, going from the places where I think there's a lot of exciting alignment, but I can't, even if we come at this from different places, I wanted to share a little bit about the Medicaid expansion piece and why I think it's the right time to do Medicaid expansion here for North Carolina and do it in a way that makes sense for our state. So first, I want to talk about cost shifting in healthcare. Anyone who's close to healthcare knows that there's a lot of cost shifting, meaning that there's a ton of uncompensated care that goes on in our system. And in order for hospitals and others to just keep their doors open, they have to take money from different pots to cover those uncompensated costs. So here's, more patient stories. So you have someone who's been uninsured, has high blood pressure for a long time, it goes untreated. What happens when high blood pressure goes untreated for a really long time is that you're at high risk for stroke. When you come in with a stroke, not only are you coming into an emergency situation and folks throw everything at you to try to reverse the stroke, but if they can't, then you're permanently disabled sometimes, right, with difficulty walking or talking or moving, right? And so now we've actually are putting a burden on the system. One, if someone doesn't have insurance and needs a crisis intervention, that hospital is required by law to provide that crisis intervention, but it doesn't isn't ever able to bill and recover that. It forces a lot of folks into medical bankruptcy. It's not going to be surprising that North Carolina is one of the states with the highest amount of medical bankruptcy. So they're not able to recover those costs. So when they go to negotiate with Blue Cross Blue Shield for all of our insurance, right, in the employer space, they say, well, I got to raise rates some to cover all of these costs. Meaning the hospital has to charge Blue Cross for more for everyone in order to cover these uncompensated costs. And we see this bear out in the data now. We've had 5 years of other states expanding Medicaid and North Carolina not. And you see the states that have expanded Medicaid have had less growth in their premiums in the commercial space, right? Not huge, 7%, but in a time where the trajectory is only up, downward pressure on rates, that's a great thing. And so that's one piece. But the other piece of this is about that rural infrastructure, and where I started, which was the infant mortality statistics, the opioid crisis statistics, that disparity that we're already seeing in the rural-urban divide only gets worsened because our rural communities have a higher rate of uninsured than even in our urban areas, even though the sheer number of people uninsured in urban are larger. And so we can see what's happened in other states, whether it's a Kentucky or others, that when they were able to move to expansion, it really did help their rural hospitals and their rural infrastructure in a different way. And look, we're a rural state, and I just want every tool at my disposal to make sure that folks can get access to care, and I think it's an important tool. The other is opioid epidemic, and we'll get to a little more on opioid in a second, but I look at a close by state like Ohio, and they were really hard hit by the opioid crisis. And I look at somewhere like Dayton, Ohio, there was this big report on how they were able to cut overdose rates by 50%. Now I'm going to show you some statistics where we're doing okay, but we're still going up. They cut it by 50%. And when you talk to the folks there, whether it was the mayor, whether it was Governor Kasich, all said that Medicaid expansion, while not the only thing that mattered, was a critical component for them to be able to do that. And then I can talk about the expansion on economy and employers, again, from a jobs perspective as well as from a downward pressure on premiums perspective. So I'll leave it there. And I know we come at that issue in particular from different spaces. I think that I'm encouraged by the dialogue that is developing, because I think there is a way to craft a solution that works for North Carolina. I'm definitely open to talking further on those, and as well as taking your questions on this, but I wanted to at least present sort of how I think about the positives of Medicaid expansion for our state. Okay, let me talk on about opioids and early childhood in a much briefer way than I just did on Medicaid, but then I'd love to take your questions. So overall, where we are with the opioid crisis today, we've been able to get a lot of grant dollars. In a good way, there's been a lot of attention to the opioid crisis, which is important, and that we've been able to get a lot of grant funding. But as anything, grant funding is short term. It really isn't allowing us to think about sort of the longer term investments, because a lot of our dollars do need to go into treatment. Where I look at, again, our partners in Ohio, they've been able to use their Medicaid dollars to pay for treatment, and then they use their grant dollars to really think about all of the wraparound infrastructure that's needed. So we're making some improvements, and I'm very proud of all the work that folks are doing. We've seen a decrease in the number of prescription pills that are written. We used to have one for every person here in North Carolina. We've definitely seen that change, and thanks to the physician community on that. And we've also seen opioid overdose visits in the emergency room. We had this big spike, as you can see here, right around the time when we started a coordinated action plan. We saw that come down, which was good. But like I said, I want to see that come to 50%, right? I'm competitive with those other states, and we can do that, but we're not there. We're not there yet. We do have the ability through Medicaid to do some additional spending on opioid treatment and to use Medicaid dollars. I won't go into the details here, but again, opportunity through our waiver process to use our dollars a little bit differently to help those who are already Medicaid beneficiaries, but they'd have to be in the Medicaid program already to take advantage of this. So where we're able to take advantage of this, we will, and we're going to be starting some of these new programs earlier this coming year. So a moment on early childhood health, safety, and education, because this is, if you think about, how do we really invest in health, right? What if there's, one thing that I would want us to do in terms of investing in health, to get upstream of the chronic diseases and get upstream of a lot of the issues that happen over the course of someone's lifetime, it's really to think about early childhood. It's about the brain development. Science tells us that really intervening 0 to 5 is so critical for someone's lifelong trajectory around health. We know if they don't develop good, healthy habits young, that they likely aren't going to change them. They can, but it's not as likely. Same thing with the early learning. If you're behind when you get to kindergarten, you often stay behind. And so how do we think about getting ahead of that? And so if we look at some of the statistics for North Carolina, we've made a huge investment in North Carolina around early learning. The business communities have been very engaged in this. I know John Locke has written a lot on this and we've made a lot of progress here. But if you look at all the pieces around learning, the health and the safety, we still have a lot of work to do. So children's overall health ranking 30, we know we rank 46 in terms of kids who are uninsured. You can see kids who live in poverty, kids are food insecure, right? As well as we're seeing a 25% increase in foster care. We know that is directly related to the opioid crisis. So a lot of work to do related to kids' health and well-being. And so I wanted to bring together certainly my department as well as all the stakeholders who think about early childhood to come together in a coordinated way. And again, this is about really thinking about where the role each of us play here and how do we really focus ourselves and prioritize. And so we've put together a draft of an early childhood action plan. It's very metric driven with some very defined outcomes in 3 buckets: healthy, safe and nurtured, learning and ready to succeed. It's an extensive plan. I'd love for all of you to take a look at that and give us ongoing feedback. Again, I think it has a lot of focused metrics in there. Again, you're going to see infant mortality, but you're also going to see social emotional development and 3rd grade reading levels and things like that. So it's a really good plan, and I'm hoping that when we get to a final version, which we're hoping to do by the end of this month, that it can be a way for us to all be focused together on how we invest in kids. So I'm excited about this plan. I couldn't do it justice going through all of the metrics here, but I encourage you to take a look at that and to join us. There's an early childhood summit at the end of February in which we're going to be rolling out the final version of it. And I hope that can be a galvanizing moment for us all to say, not that anyone's doing the wrong thing, but how do we focus and prioritize to really move the needle on health and safety and learning in a coordinated way. I'll tell you, my department needs to work differently in order to do that, right? I need the folks who run, for example, our WIC program, which is a food and nutrition program for pregnant moms. I need those folks to work way more collaboratively with our Medicaid program, for example, right, to make sure that kids are healthy. I need the folks who worry about early childhood learning in one part of my department to work closely with those who think about moms' jobs, right? We have a big jobs focus in our department. Moms' jobs definitely relates to how well childhood educational attainment goes, right? So those are the kinds of ways in which I'm hoping our department can lead the way in thinking differently and breaking down some of the silos here to get to some of these important outcomes for our kids. Okay, so that was a lot, but I was racing so that we can get about 10 minutes here so I can answer some of your questions. But thank you again for this opportunity to talk you through where we are at the department. Again, I think there's a lot of alignment and in the ways in which we are trying to do our work, and I look forward to your questions. Thank you.
Terrific. Let's start with our research analyst here who specializes in healthcare. This
Perfect.
is Jordan Roberts.
Hi, Jordan.
Hi, thank you for being here.
Sure.
So I think it's safe to say that a lot of care delivery has been centralized into hospitals. And so my question is, in your estimation, what would Medicaid expansion, what would the effect of Medicaid expansion be on the supply side of healthcare? And what policy tools are at the General Assembly's disposal to ensure that patients and the state is getting the best price for healthcare?
It's a lot embedded in that question. Fundamentally, I think the way in which we're trying to move forward with managed care is trying to get at that balance. I think you're seeing a lot of practices get bought up by hospitals, and that has to do, with a lot of economic factors as well as the complexity of what healthcare is right now, right? So one, we're trying to deal with that complexity and saying, look, I'm trying to think about administrative burden. But also, we are very much, as we move forward in managed care, saying we want to empower the independent practices to do care coordination and to give them a revenue source to do it, right? They're often already doing care coordination, but it's, again, it's part of that cost shift of many things that they're trying to just do the right thing despite the system not working well for them. And so we're trying to give an opportunity for revenue to flow to those practices so they don't have to feel like they have to get eaten up by a hospital. So that's one way. And so as we think about Medicaid expansion, all those expansion, that population would go into managed care. And again, I think it is a revenue opportunity for independent practitioners, again, to keep that balance between those that are practicing medicine outside of hospital setting and the hospitals. I think that's good overall as a payer of healthcare as I think about that. And then as far as what the General Assembly can do, I think this is where we want to have a conversation with the General Assembly about what does that North Carolina solution look like. And I think there's been good discussion about those policy parameters, and I look forward to that conversation. And I do think that there's a consensus position here. I'm trying to keep everyone from get into their corners because that can happen really quickly. But how do we find a solution that everyone can live with? And that's sort of my goal.
All right, former State Representative Marilyn Avila.
Hey, Marilyn.
Back in the beginning, you gave an example of a patient who had personal life issues that impacted reasons for health issues. And your solution was to find innovative ways to solve that problem. We have an issue where we've got a lot of people who don't have insurance. And why are we not looking at innovative ways to give them insurance rather than just go put everybody on Medicaid?
Well, I think that's a bigger question than just me, and I think looking for a variety of solutions is totally right. But I don't want to do that at the expense of turning away, a huge amount of federal dollars that can help us move the needle. I think looking at other options is totally right, though. The one that is sitting there saying no state tax dollars, $4 billion in federal dollars that can help 500,000 people, right? I think that's one piece of the solution, but I definitely agree that there can be other solutions out there. We want to make sure that folks are protected as they get that insurance, right? I think that is why we want to make sure that folks know what they're buying when they buy it and that they get good protections of it. But I think I'm always open to looking at other alternatives and seeing how we can put a package together that makes sense.
Other questions and comments? Yes?
Yeah, thank you, Dr. Collins, for a very nice presentation.
Thanks.
Has anyone looked at the expansion states' budgets, how they were predicted, and what actually happened? There may not be enough data on it yet.
Yeah.
I'd be interested in seeing as to whether or not the costs went up or whatever they were supposed to do as projected compared to what actually happened.
Yeah. I don't know the answer to whether the studies are out there. What I would say is that I think the discussion here in North Carolina has been centering on not having to have state tax dollars as part of the investment here to do Medicaid expansion, meaning that, so the way it's structured is 90% is paid by the federal government, 10% needs to come up with the state, but the state can raise that money in different ways. They could raise it with tax dollars, or they can raise it through hospital assessments and other provider assessments. And sort of that's the way that I've heard most of the discussion focus, is that that 10% is not going to come from state tax revenue. So it's going to come from other sources. So if things were not as projected in terms of budget, it wouldn't impact state tax dollars. It would impact sort of the folks who were going to be assessed for that 10%, and it could be scalable. So I think even if enrollment was higher or different than things are budgeted, I think we're protected from a state revenue perspective.
Let's see. Ma'am, did you have a question? No? Okay, I thought I saw you.
That 90% that comes from the federal government, that's not forever and ever. That's just for a year or two, right?
It is until Congress would act to say it's not. So it's forever until Congress would act to say it's not. And I understand that, but I think we've seen over the last number of years, last couple of years, more uncertainty on that forever. I think now in a place of what's the divided government, is that I don't think there's going to be a lot of movement in the healthcare space. And so that 90% is in perpetuity until Congress would act differently. I mean, but they could act differently right now on my Medicaid program and the amount of federal match we get at any day. So, yeah. Sorry. Oh my God. Okay.
If we accept the 90% from the federal government, what other obligations do we come under?
Well, so I mean, the obligations would be to provide that population with a certain defined set of benefits, right, insurance benefits. But there's no other strings attached in terms of but maybe you're thinking of something that I'm not honing in on. But I don't believe that there's any other strings other than if we take that money, we're going to provide that eligible population with covered benefits. Yeah. Yes.
I spent a number of years in Warren County. In fact, I was chairman of the Board of Health. And one of the problems up there is access. There is no hospital. There are no doctors.
Mm-hmm.
And are you guys looking at in fact, the health department there occupies what used to be the hospital. And access up there is a real problem.
Yeah.
So whether or not you have insurance,
Yep.
it's still getting the people
Yep.
to a doctor.
Yep. No, I think it's a huge issue for our state, and it's one in which is why I would say, right, insurance card is only one step in the process here, right? And you need to make sure that there's going to be qualified doctors to be able to see folks. But it's a little chicken or the egg, right? We see a number of rural hospitals really struggling in our state right now. They've been very public. They've been in the newspaper. And either are needing to be bought by bigger hospitals or just close their doors. And so what I'm worried about is sort of stemming that tide. Let's not see any other closures, but at the same time, we really need to have a discussion about like what does access to care in rural areas really look like in the future. A big part of that is going to have to be telehealth. I think it's going to be unrealistic for us to say that we're going to put a specialist of every kind in every county. We're not going to be able to do that. I think folks know that. But so what are the ways in which we can do that in a smart way so that quality can stay high and use telehealth, but that means some other infrastructure things like broadband and others that can support that kind of an infrastructure. And also, what is the physical plant? Is it a hospital? Is it an emergency room? Is it urgent care? What's that mix? And I frankly think that North Carolina is well positioned to be a state that can answer some of those questions for the nation. I don't think we know all of the answers to, and I think that different hospital systems are trying things out, and we're going to learn a lot of lessons over the next number of years. But I think you're exactly right. I should say, in our waiver package, we did ask for some additional support from the federal government around workforce. It was one of the things they said no to. You don't get a yes for everything, and that was one of the things they said no to. So we're sort of going a little bit back to the drawing board to figure out how can we still support what we wanted to do without that extra federal support. Yeah.
John?
Dr. Cohen, back to this question about the federal share of the Medicaid expansion. I think one of the things that makes it seem implausible in the long run that the 90% ratio will stick is that the feds right now under the ACA would be paid 90%, as you know, on relatively lower cost, mostly childless adults coming into the expansion population, and then a much lower amount for the really costly cases, folks with significant disabilities, families with children, etc. And it just doesn't feel like in the long run that's a distribution that would stick. Now, in fairness, it could be some future Congress would redo the ratios so that they would pay more, they would raise it for the costly caseload and reduce it for the Medicaid expansion population. We don't know how North Carolina would fare. Obviously, some states would do better than others based on their proportion of high cost to lower cost. But that's the reason, and it seems really incredible to imagine 90%, in our case, what is that, 60, 70%,
Yeah,
or whatever.
exactly.
It just feels
Well, I think you're pointing out a great challenge of healthcare in that we're not able to predict cost in a way that is in a way that always maps to our reality. And so what you wind up with is this very complex system of financing around cost shift, right? And it's hard to imagine changing one thing and fixing it all, right? Because there's so many complexities to that cost shift. And so I hear what you're saying is like, why are we paying more? And again, that is, I think, relative, right? More for for the type of care, right? So overall, if you look at, as you said, that population is going to be generally healthier. The level of reimbursement for that, even though 90% is covered, is still going to be a lot lower than the what we get from yeah. And the other hard part about this is often, folks get sick at different times, and so you never know, is someone going to be that high cost person versus the low cost. And some of what we are trying to do, for example, in this Healthy Opportunities work, is understand that person's risk, right? We're already trying to target those high risk, high cost patients, but the newest research is really around the rising risk. Like, how do you get them before they get the stroke, right? How do you get to the rising risk, intervene in a smart, low cost setting way, and really keep them from becoming the disabled, right? How do you keep them just taking their blood pressure med, not getting a stroke and becoming disabled and becoming that high cost? So that's a lot of what we are hoping to refine and learn over this period of time. I think you're right in saying, could someone come in and look and be like, this is crazy, we should do something different? Yeah, I think healthcare financing, I don't think anyone would say is is straightforward. And so, I think someone could do that. My goal continues to be like, look, we have an opportunity to get more people healthcare coverage and at least decrease some of that cost shift that's happening within North Carolina. Let's take advantage of that. Let's get everyone in the tent. Let's get everyone to those low-cost settings. Let's manage their care, manage things well, and then let's take a look at how can we do this better. I think that's always a fair thing, but like I'm looking at sort of like the incremental things of what can we accomplish here in North Carolina this year.